Hi, I'm Warren Snowden, Minister for Indigenous Health, Rural and Regional Health and Regional Services Delivery. It's my pleasure to introduce this program produced by the Rural Health Education Foundation and which is funded by the Australian Government Department of Health and Ageing. 5 years ago, approximately 700,000 Australians had diabetes. Just 3 years later, the number had jumped sharply to more than 818,000, or 4% of the population. The majority of those, 88%, were cases of type 2 diabetes. Every day in Australia, about 275 adults develop some type of diabetes. There are, on average, 10,600 deaths each year where diabetes is the underlying and associated cause, which represents about 8% of all deaths in Australia. In Indigenous populations, the figures are far worse. The prevalence of type 2 diabetes amongst Aboriginal and Torres Strait Islander people is at least 3 times higher than for non-Indigenous Australians. And incredibly, the rate of all types of diabetes amongst Indigenous Australians in some remote communities is as much as 10 times higher. Yet type 2 diabetes is considered to be largely a preventable disease. This program examines evidence-based approaches to the management of diabetes, hypoglycemic control and diabetes-related complications amongst Indigenous Australians, and is part 4 in a series of type 2 diabetes and the new NHMRC-endorsed type 2 diabetes mellitus clinical guidelines. This program will assist GPs, Aboriginal health workers, diabetes educators and all primary healthcare workers in providing support and good care needed for Indigenous Australians with type 2 diabetes. I commend this broadcast as a key tool in improving Australia's performance on this important health issue. I strongly believe that a better understanding of how to prevent, detect and diagnose diabetes in Indigenous Australians will lead to improved health outcomes and life expectancy for all Indigenous communities.
Thank you, Minister. I'm Norman Swan. Welcome to the 4th programme, as he said, on type 2 diabetes guidelines and looking at diabetes in Indigenous Australians. And on behalf of everyone, I'd like to acknowledge that we're meeting on the land of the Wangal people. The Wangal people are the traditional owners of this land and form part of the wider Aboriginal nation commonly known as Eora. We also acknowledge elders past and present and the descendants of the Wangal people. Diabetes accounts for a significant proportion of the gap in mortality rates between Indigenous and non-Indigenous Australians. And as the Minister implied, this programme focuses on a comprehensive and culturally appropriate multidisciplinary approach to prevention, detection, diagnosis and management amongst Indigenous Australians. Now, if you're watching on your computer, you have the facility to type your questions in directly to the studio. Just type your question in the live talk text box below the slides. That also means, of course, that we can ask questions of you, and here's one to get you going. Tell us where you're located in metropolitan, regional, rural or remote Australia. And we'll come back to the answers to that in a moment. As usual, there are a number of useful resources available to you on the Rural Health Education Foundation's website, rhef.com.au. Now let's meet our panel. Dr. Pat Phillips is the Director of the Diabetes Centre and Endocrinology at the Queen Elizabeth Hospital in Adelaide and has been for many years at the forefront of diabetes research and treatment and oversees the State Diabetes Outreach Programme. Welcome, Pat.
Thank you.
What is the Diabetes Outreach Programme in your state, in South Australia?
It's really built around building capacity in rural and remote areas. So it's focusing on the health professionals and trying to give them a better capacity to deal with diabetes in their communities.
So it's not parachuting in services, it's getting the local services to be able to do it better?
The principle is that if we can get the locals to do it, it's a bit like teaching someone to fish rather than giving them fish.
Dr. Rob Way is a general practitioner at Katungo Aboriginal Medical Service in Narooma, New South Wales. Welcome, Rob.
Thank you, Norman.
You'd have a few people in your community with diabetes?
We have a few of our population, yes, with diabetes and perhaps a few with diabetes to come.
Sumara Corpus is an Aboriginal health worker and diabetes educator from Darwin. Welcome, Sumara.
Hello.
And we're going to be talking about your programme in the top end shortly, which is quite actively going out into communities looking for people and helping people with diabetes.
Yep.
Bernadette Heenan is a credentialed diabetes educator and registered nurse from Far North Queensland Rural Division of General Practice in Cairns. So you're actually providing services.
That's right. Yeah, we parachute in.
And doing that, right, can't get away from it. Well, again, we'll come back to both your experiences and Sumara's later. So Pat, do you have anything to add to the statistics the Minister just gave?
I think that was a very fair summary. Diabetes being very common and up to 50, 60, 70% in some Aboriginal populations, depending on their age. I think there's also a good point made about the complications and the excess mortality in Aboriginal people related to cardiovascular death and renal disease, in particular those two. And I think the other comment which was really important was that it's a disease that unfortunately is so common amongst the Aboriginal population that you almost have to assume that someone is going to get it and start looking for it and treating it very, very early.
Bernadette, is it different amongst Indigenous people, Aboriginal, Torres Strait Islander people than in the general community?
Yeah, I think we notice it certainly in the areas where I work. A lot of the clients that all the clients, most of them I see have got diabetes, and there's certainly a much greater proportion in each of the communities that I go to that would have diabetes than you'd see in downtown Cairns, say. So.
But how different is it from non-Indigenous people?
It's hard to know to what degree it's a different disease in the sense it's much more serious than in non-Indigenous people, because the Indigenous people have more risk factors, so they have more hypertension, a lot of dyslipidemia, a lot of central overweight. It's also not clear also whether it may just be something that they're genetically predisposed to. And the third potential factor, or at least a third one, is the prenatal environment, so that their intrauterine environment is often breeding a tendency towards diabetes, metabolic syndrome, renal disease, even before they're born.
And the incidence of kidney disease secondary to diabetes is huge compared to the non-Indigenous community.
Very, very much so. So 30% of the population with type 2 diabetes, non-Indigenous, may develop microalbuminuria and potentially chronic kidney disease related to diabetes, whereas it's 70, 80, 90% of the Aboriginal people with type 2 diabetes, and is a major cause of some of the other complications like cardiovascular disease.
And that, of course, Rob, changes the way you look after people.
That's right. I think we're looking at everybody as a work in progress, and we're just trying to make sure that we minimise the risk factors as soon as we can. And actually, you know, I think I treat everybody walking through my door with an Indigenous background as pre-diabetic.
Samara, what impact does all this have on communities?
It has a great impact because they're not functional at a higher level. A lot of people go to town for dialysis, so it's disrupting the family everyday activities. And the support, there's no support. Like in the Territory, they have to come, say, 800 kilometres to live in town, and they can't live in their own communities. So they're taken away from their homelands, more or less.
And how much awareness do you think there is?
There's a lot of awareness, but I think we have to just do more promotion, health promotion, and start in the schools.
How young is the youngest person with type 2 diabetes you've come across in your community, Samara?
The youngest is 10-year-old.
10-year-old?
Yes, and that's from out in a remote area. And now she's about 12 now, and she's on oral hypoglycemic medications, and for that age to have tablets every day is really hard.
Sure is. What's the youngest you've seen, Bernadette?
9 years of age this year, and she started on metformin straight away.
And Rob?
14. And that presentation was with sort of acanthosis nigricans. So, you know.
So this is something not only happens more frequently, it happens at an earlier age.
And it also means that the children who develop their type 2 diabetes, should they survive, they get the metabolic consequences of having type 2 diabetes and the duration of having diabetes that occurs in type 1 diabetes. So they get the complications of type 1 diabetes and the complications of type 2 diabetes. So they get a really bad set of problems.
And we have the results to our first poll question. Where are you located? And metropolitan, a third of you, regional, a third, and rural, a third, and nobody's admitting to, well, a small percentage, in fact, are admitting to being in remote. So it's a pretty 8.3%. And welcome to you all. And I just wouldn't mind just checking your level, or your self-perceived level of knowledge. Are you aware, do you think, of all the risk factors for type 2 diabetes in Indigenous Australians? Yes, no, maybe a bit. And we'll come back to the answers to that in a moment. Let's go to our first case study. Jim is a 30-year-old Indigenous man with a wife and 3 kids living in a remote community. He's unemployed. They family shares a 3-bedroom house with another family of 4, and all the 4 adults smoke. There's one store in the community. Jim enjoys playing cards, having a few drinks with his mates, and occasionally goes hunting in the community Toyota. Jim's mum was diagnosed with diabetes at the age of 50. What's your assessment of Jim, Sumara?
Jim's, with his mother being diabetic, it's a risk factor, and being inactive is another risk factor, and not working, and alcohol, smoking, they're all risk factors, so yeah, it's not too bright for Jim.
So if he's, even before you do a single test on him, the assumption is he's pre-diabetic and he may already even have diabetes?
Yeah, most probably undiagnosed, yes.
So if you don't have experience dealing with Aboriginal communities, looking after people in Aboriginal or Torres Strait Islander communities, you might throw up your hands in horror and say, well, what could you possibly do? Well, I'm going to ask you, what can you possibly do about someone like Jim in your experience?
Just talk to him, tell him the truth, and see what he wants to do. Like, you build up your rapport and inform him on his risk factors and what's going to happen to him, and see what he wants to do about it. If he wants to start diet, exercise, just small goals, just to start with, would help.
And what do you find motivates?
Well, to motivate him, employment would be a start. Getting the community involved, community-driven.
What does that mean?
Activities.
What does that mean, though? Not taking the Toyota when you're going out hunting, or what?
Well, they can go out hunting more often, using the community's vehicle, doing community activities with other families.
Do they get much exercise going out in the Toyota, though, rather than sort of getting out and walking?
No, they don't get much exercise, but what I'm saying is going out to a spot and then go hunting from there. Yeah, a lot of communities are starting to do that now. So, taking people out and just leaving them out there.
How practical is looking for bush tucker and converting from what might be a pretty unhealthy diet via the store to an expensive diet versus collecting your own bush tucker?
There's a lot of bush tucker out in the territory, and they can do it. It's just easier going to the shop. I promote going back to bush tucker, hunting and gathering, instead of just going to the shop and buying meat, where it's much more healthier. They have to walk, they have to work for it, and they have to chase it, so that's natural.
One of the traps I had was one of my patients was telling me, oh, he only ate bush tucker, and this is in Tennant Creek, and what he meant by that was he ate a lot of kangaroo tail. So he went down to the shop and they got the kangaroo tail and ate that.
But that's not bad, that's lean meat, isn't it? Or is that pretty fatty?
That's where the kangaroo store thought it's fat.
Fat, all right, so the kangaroo tail's not a good idea. And how would you monitor Jim then? What sort of things would you be looking for in terms of, or getting him to monitor himself? Would it be things like waist circumference, or you wouldn't even?
Start with waist circumference, ask him to see if he can start 30 minutes a day, and weight loss, look at weight loss, and just set small goals, and then he can grow on them and make a change.
Bernadette, what would be your approach?
Very similar, personalised to suit him. We'd give him a self-management folder and try and teach him a lot about best blood pressure, what to aim for. We even encourage our clients to self-blood glucose monitor, even if it's only before and after a meal once a week. And we use lots of visual stuff, so rather than having them write it in diaries, we get them to download their monitors to laptops. So we use all the latest technology, even if it's out on someone's veranda or out somewhere. We just take our laptops with us, and so we do lots of pictures of this is when your blood sugars weren't so good and this is what's happening now. So there's always before and after shots, and always positive stories, so positive role models.
Samara, you've developed some materials to actually help people detect the symptoms of diabetes.
Yes, we did this in Darwin, and it's how do you feel, and these are signs and symptoms. We've done 5 chapters, so we went to what now I have diabetes, taking medications, doing BGLs, and just helps them understand what they're going through, and it's a good tool, and it's on the web.
So just show us a little bit of it.
Okay. The first steps is being lethargic, sleepy, no energy, and they can relate to that, and they say, oh yeah, that's how I've been feeling. Some people are up all night going to the toilet, so the first thing you say is, how many times do you actually get up to go to the toilet? And then, you know, that sends alarm bells, okay? And then you can say, well, going to the toilet, if you get your blood sugars down, because your body's trying to get rid of that excess sugar in your body, and it's making you get thirsty, and the body's trying to get rid of the excess sugar. So they're urinating it out.
And if people want to get a hold of some of these materials, how do they do that?
Contact your local diabetes office, or look on the web under Diabetes Australia.
Let's talk now about more active prevention. Pat, what other more active things can be done? I mean, for example, is there any role in Aboriginal communities for obesity surgery?
I guess that's a question I haven't thought a lot about, because I would imagine it's very difficult to access, and also very difficult to support the person through some of the things that are associated with bariatric surgery. So if you're going for the malabsorptive surgery, for example, that really takes quite an investment in terms of education, nutrition. And if it's lap banding, it's once again teaching people not to switch from solid to liquid food, which will just obviate the... So I'm not sure that they'd get the sort of support after the surgery which is likely to make the surgery successful.
And is there any evidence that intervening in Aboriginal, in Indigenous Australians, with their high risk of oral hypoglycemic agents or even insulin early, actually helps to minimise the course?
There have been some, not totally well controlled, but some intervention studies, and in particular relating to the kidney disease that I was talking about a little while ago. And in northern Australia, in the Tiwi Islands, there's a program which was organised by a doctor, Wendy Howe, who thank you, who actually basically gave everyone an ACE inhibitor, an angiotensin converting enzyme inhibitor, because of the problems of chronic kidney disease, hypertension, and showed a progressive decrease in both the total mortality and also the progression to end-stage renal failure. So it was, in that sense, historical controls, but it was a demonstration that A, it was feasible to do this on a population-based scale, and B, it seemed to be effective.
So what do the guidelines say?
The guidelines suggest that an ACE inhibitor is a preferred medication in type 2 diabetes if the person has hypertension. There's also been trials in non-Indigenous people that an ACE inhibitor has benefits in those who have type 2 diabetes and one other cardiovascular risk factor. Of course, everyone's got one other cardiovascular risk factor, so it's virtually everyone with type 2 diabetes. That was the HOPE study. It's been repeated with other ACE inhibitors. There have not really been a lot of intervention studies which have been done in any sort of trial basis in Aboriginal populations. So the diabetes prevention program, for example, was an American program and has been repeated in lots of other countries using metformin. Other drugs have been used, the glitazones, acarbose, several other drugs have been used.
But not proven?
Not in the Aboriginal population. In those populations that did reduce the progression of pre-diabetes to diabetes.
Let's go to our first case study, or sorry, our second case study. This is a filmed case study. It involves Greg, a 37-year-old Indigenous man who presents to Western Sydney Aboriginal Medical Service at Mount Druitt in New South Wales. He's screened, diagnosed with diabetes and engaged in an intervention. Let's take a look.
I think once you've seen Indigenous patients who are very young, having diabetes, having heart attacks, having all sorts of vascular problems, as we see in this setting, it really gets your radar working, and you have to apply the screening tests at an earlier age than you would elsewhere. Greg? This morning, actually, a patient of mine called Greg is coming back to see me. I saw him last week. We were discussing diabetes because he has a few family members with the disease, and we did some tests, in fact. And today he's coming back to have me tell him, unfortunately, that he does have diabetes.
Oh, I hope you got some good news for me.
All right. Well, look, yeah, last week we were discussing diabetes, and because Greg is getting on into his late 30s, almost 40 now. Quite a young man for someone to be diagnosed with the mature onset type of diabetes. But being an Indigenous man, he has an extra layer of risk, we might say. He's not a big man, he's not the shape that makes doctors think, well, that person's a sitter for type 2 diabetes. But I guess it goes to show that being Indigenous and even just being a little bit overweight, they are risk factors enough to actively look for diabetes.
Can it go away? It's going to be there.
It's something that will be with you for life. But before we get too far ahead of ourselves, I'd like to go back to sort of explaining what diabetes is all about. You've probably it's very important to actually make sure the patient knows the consequences of having poorly managed diabetes. And, so we're talking about problems with the feet and problems with the eyes in particular, but there are also problems as, with the heart and kidneys and brain. And that's a good starting place then to say, well, what can we do about it? How can we prevent those things from happening?
Okay.
If we're going to move forward now and manage this effectively, we want to involve some key people in helping you to manage it. It's important simply to have a very explicit, listed plan of what's going to happen next and with whom, so that everyone knows what's going on and nothing is overlooked. In the first instance, I referred Greg to the Aboriginal health worker whose specialty is diabetes, and Louise has a very good understanding of the disease and can talk to Greg about that in a way that make it easier for him to understand that perhaps I wouldn't be able to do so well. So he's in the waiting room now.
So you want me to have a little chat to him?
If you could.
So what have you been through with him?
A bit about... Apart from that, obviously being Indigenous herself, she has that sort of innate cultural awareness and ability to attend to perhaps slightly different issues that would be different from my perspective.
Just a question, did you understand what Dr. Bill was talking about?
Yeah, I did, but just he told me that there's ways of controlling it, and so I just would like to talk about what things to eat now. And
Okay then, so when a patient like Greg or any of my patients come to me, I would normally talk to them about diet changes, exercise and the complications that diabetes can have in the long run if their diabetes is not managed. Did he put you on any medication?
not as yet.
No, so that's good. So we're just going to go on diet control at the moment. Yeah, you've got to try and focus on the first thing. Like Greg today, really about his diet changes, because it's a big shock to their system, like they're coming in newly diagnosed, and you try and tell them all these things, they're just going to forget about it mostly because they're still in a bit of a shock. You might just have to explain it a bit more in simple terms. you know, your diet. And
Okay.
well, next time you go shopping, you might want to look at this and say, well, you know, go at the back of you and say, oh, on my shopping list, I might choose from this today, you know, on the shopping list, and your different choices. One thing too I do encourage is that they do get a glucometer so they can measure their sugar levels, so they can keep an eye on it to see what's going on. But, you know, a lot of our patients can't afford it sometimes, so, but they do come in here and we can do it in here anyway if they can't afford to buy their own glucometer. So what have you eaten this morning, Greg? Have you?
Oh, this morning I had some Vegemite on toast.
7.9, that's still a little bit high. So is that what you had, Vegemite on toast?
I had a meat pie.
Well, once the patients attend the service, you know, it's usually a team approach. We do have a lot of our visiting specialists coming, like a podiatrist, a diabetes educator, so that's all done. But as for the eyes, we need to send them out.
So you booked in for a week's time?
I'll book you in for a week's time with Heather.
So I'll see you in a week.
Yeah. We can only do so much as health workers. Most of it we try and encourage it, put it back onto the patients themselves, like for self-management, by buying a glucometer, checking their sugars, having regular checkups, making sure they're taking their medications. I'll see you next week.
Thanks, Louise. Thanks a lot. Have a good day.
We still have a lot of our patients that have gone down the track and, you know, ended up on dialysis. It'd be so nice to catch these patients early before it gets to that stage, I suppose.
After all, I know things not 100%, but at least I'm still going to be here for as long as I can, and with the help of the Aboriginal health workers here.
Greg's story from Mount Druitt in New South Wales. How typical is that, Rob?
Oh, it's very typical. Mind you, Greg looks quite motivated and probably not too daunted by his diagnosis. And whereas occasionally we find people who are quite upset, quite concerned about a diagnosis. And so I think Bernadette was talking about emphasising the positive. The thing I'll be making sure that Greg knows is that it's great that we picked it up as early as we have. Hopefully it's, you know, within a few months of his blood sugar popping up, so that we can start all these preventions.
The guidelines that we're using here, there's a general practice set of guidelines too, are there not?
Yes, and there's, I don't know if we've got a slide of that coming up, but there's some excellent diabetes management guidelines that cover pretty much most of the questions that we're touching on today.
Just going back to the earlier point about screening, how regularly do you screen people in an Aboriginal community?
In an Indigenous practice, I screen everybody every day, every time they walk through the door. So as a set process, they get their weight. We measure their waist regularly, and we check their sugar probably at least once a month if they're popping in.
What about you, Samara? What's your advice?
We do waist-hip ratio, weight, BGL, blood pressure.
Do you use a risk tool with them, or do you just assume everybody's at risk?
No.
You just assume it's everybody?
It's not designed, they've never took it into account for Aboriginal people, because they've got the Aboriginal and the Asians together, and they're totally different body shapes and ethnic backgrounds, so it doesn't work.
And Bernadette, you try and personalise the approach to somebody like this so that they've actually got their own book.
Yeah, we've got a self-management folder that we use for people. So we tend to take their photo and give them a whole book that's dedicated just to them. It's full of lots of handouts and things that are actually showing what their blood pressure is, what their blood glucose levels are, what their HbA1c is, and there's lots of outs done by our doctors, dietitian, podiatrist, etc., on how they can actually look after things themselves. So they're...
You even have an appointments book in there.
Yeah, there is an appointment book, yeah, with the whole 10 or so people who, we call it the mob, who help me look after my diabetes.
Because
so
what we haven't said is, but a lot of people watching know it, this is multidisciplinary
team. You can't do it any other way, yeah. So that's what this is about, and the idea is that it's something big. So our clients, it's harder to lose. The original patient-held record, you put it in your wallet and you lost it. This is so big that it's hard to lose at home, and hopefully clients will bring it with them to other appointments. So we've even had people turn up in Cairns to see their specialist, and they brought their folder with them, and the specialist has written a letter back to the GP up in the Cape saying what happened on the day. And then you're also empowering the client so much, because they're in charge of that communication between a specialist and another doctor. So it's very much tailored for them, and we invent things as we need them.
Just before we go on, let's take the results to that poll question. Are you aware of all the risk factors for type 2 diabetes in Indigenous Australians? And half of you say yes, and the vast majority of you have at least partial knowledge, and no is 12.5%. Thank you for being so honest, 12.5% of you. We'll ask another poll question now, which is, does your service have a local Indigenous diabetes education program to which it can make referrals? Yes, no, or it's part of your own service? So let's hear what the answers are to that. What are the treatment options for Greg?
Well,
I mean, the guidelines say start with lifestyle, yes, but some people would argue with Aboriginal people, given their high level of risk, you might move a little bit more quickly.
Well, actually, the Americans and the Europeans have both sort of adopted that second approach. That is, you've got type 2 diabetes, you counsel people on lifestyle and start metformin at the same time. Australia, we tend not to do that. We tend to use lifestyle first and then add in metformin fairly shortly thereafter. It does have the advantage, if you focus on lifestyle, is that you're not taking their diabetes away from them. So that you've just been diagnosed with type 2 diabetes, and I give you a pill and say, take this pill and that's all you have to do about it. Then the diabetes is now my problem. I'm prescribing the pills. You just take the pills and that's the end of your responsibility.
If the pills don't work, it's your problem, doctor.
Yeah, that's right. But focusing in on the lifestyle, engagement in the lifestyle and engagement in understanding diabetes, and then using the medication, it might delay the medication, starting the medication by a little while, but probably not much more than weeks or a month or two. And in the context of the type 2 diabetes, actually engaging the person in their self-management is really very important.
And what about this incredibly high risk of kidney complications?
I think there is a very strong case. Now, I'm not a practitioner who deals a lot with rural and remote populations of Aboriginal people, but there's a very strong case, I think, of, in much the same way, considering starting an ACE inhibitor pretty well straight away too, because you can be very, very confident that that person, if they don't have hypertension already, they will get it, and if they haven't got kidney disease already, they'll get that. And ACE inhibitors have been shown to be good medications for hypertension and to reduce your risk of chronic kidney disease.
And you don't necessarily have to have hypertension to have them?
No.
Is that what's your practice?
Well, I'm also wondering, yes, I think so. I think that we should be, there's evidence that both those medicines, delay the onset of complications. The other question would be, should we be starting a statin at the same time? Yeah.
Well, there have been several, as you're implying, there have been several studies using statins in people with type 2 diabetes. So there's the heart protection study and there's a CARD study. And the a priori guess would be that that same benefit would apply to an Aboriginal population.
Although it's stronger for antihypertensives. But, Samara, there's an affordability problem here. You have all these doctors throwing around the scripts. People have actually got to pay for the drugs.
In the Territory, because they're remote, we're under the S100. So they get Webster packs from the local clinic, and then their medication's reviewed every 3 months. So and say if they've moved, that's the difficulties, or they come to town, they leave their medications at home, and Indigenous people out bush are always in and out of town, so you just have to make sure they understand why they're taking the medications and to take the medications with them. We give them a little esky to take their insulin when they go fishing or they go bush, so then they can take their insulin with them. Just making things easy for them to take with them.
And how aggressive are you with insulin in remote communities?
We're quite aggressive with insulin because I look after the gestationals as well, and this is young girls with gestational diabetes, and the only treatment for that is insulin. So we have to look after their baby for the whole term, so yeah, we have to be there. We have to, like a lot of people say, oh, it's impossible to get them to do 4 or 5 blood sugars a day. Where if you educate them on the realistic what's going to happen to the baby if they don't, they'll do it. And people say, how can you have them on basal bolus? That's 4 injections a day. But they're willing to do it. So the right information and being consistent in what messages you're giving them.
And what about
it's really important.
Non-gestational diabetes, people with just regular type 2?
Type 2, yeah. We do that once they're on maximum orals, and then we'll start them on maybe a long-acting at night. And it seems to work, yes.
So less of a problem than you might imagine?
Yes, with the right information, right support, you can...
Tell me a bit about your program in Cape York for people like Greg, although Greg's in metropolitan Sydney, really.
Yeah, what we have up there is we're part of an improved primary healthcare initiative, and there's a group of us who travel around together, GP, podiatrist, dietitian, and a few other people, and these are the areas that we cover. So we cover a few of the remote communities up Cape York, and the Royal Flying Doctor Service covers the other areas. And we try and cover the full spectrum of primary health care, comprehensive primary health care across all the different, as well as just doing the clinical areas, we go right through to trying to educate and prevent, and prevention in terms of engaging with local shopkeepers, etc. So yeah, we try and encourage the client to learn as much about their condition as possible. That's one of the large areas that we're involved in, and the key person to our whole project is our community engagement coordinator. No matter what we do, we don't go anywhere or engage in any activities, etc., without involving that person. And as you can see from the slide up there at the moment, our CEC is the most important person. They're always Indigenous, so we have one in each of the major areas we work, the Weipa cluster, Cooktown cluster and Mossman Gorge area. So if we were seeing someone like Greg, then it would be our CEC who would go out there and make the initial contact if we were seeing him out in the community, and invite him to come in and see us, or we'd do home visits, whatever was appropriate. And we tend to be quite aggressive with our management as well.
And your booklet provides the care plan?
And the book, yeah, it's the care plan, the communication document, the education, and it's all best practice. There's no second best, second rate. It's all, yeah.
Good. Let's take some questions now from you. Kirsty from Charles Sturt University asks, how do you explain to someone with little formal education what diabetes is and the importance of regularly taking the medication? Bernadette?
When describing what diabetes is, we would often draw things. So we draw things on a bit of scrap paper, maybe on a board, whatever's available, and do a basic drawing and show what happens. We use all sorts of things, big drawings on pieces of material, or the other day we started using a clear plastic container with little balls, green balls for glucose and red ones for red blood cells, and you fill it up with 20 green balls to show how clogged things become with glucose. We use lots of analogies in our storytelling, so whether it be blue tack or chewing gum on a keyhole on a door, and how, you know, to talk about how the insulin won't work with that. So we draw pictures, We also do blood when we're putting people's blood pressures into their book, if they happen to come on the day that they haven't taken their medication this morning, you put that little note in there so the next time they come and their blood pressure's in a good range, the person is learning straight away the relationship between taking your medications or not taking them and what it's having on their body, and they're seeing it in a picture form, so you don't have to read to use the books.
And sorry, Rob?
Oh, well, I was trying to say, I think one thing that doctors often really get worried about is that understanding initially for a patient, and I think that comes with time. And sometimes, I don't know, I found when I was young and keen, I really wanted to tell the patient all about diabetes up front, and I think I just put people off. And I think really keeping the message as simple as possible so that people feel more in command of what's happening. Is actually and then go with the patient as they want to understand more. Then we talk more about the condition and go into.
And Samara, you used those materials that you were showing us earlier.
Yeah, I find more colour, the more they understand, and just keeping your messages simple, and just grow on that.
Our next question comes from Natalie in Victoria, rural Victoria, who asks, there's been mention of a traffic light food labelling program in remote communities in Western Australia. Has this been applied in other communities? Can you comment on whether you think this would assist?
Yeah, that's traffic light.
That's actually a British system, isn't it? It was started in Britain.
I don't know, I'd have to ask the dietitian that one. But I know that sometimes they use green ticks and things like that in some of the shops up the Cape. And I know it's still used in some of the healthy food programs.
A general practitioner from Melbourne asks, should there be any difference between treatment approaches between urban and remote Indigenous people, which we've kind of answered, but Pat, do you?
I think there are practical differences between the two populations, and one of the practical differences is the availability of S100 medications in South Australia and some other states. I understand they're not available in every state, but this is a Commonwealth program whereby the Aboriginal people in rural and remote parts of Australia can actually get their medication free of charge.
But they don't in the city.
But they don't in the city. And when the people from rural and remote come to the city, they no longer have access to those medications. Rob was telling me that earlier that the program doesn't apply in New South Wales, so that would make a big difference to the rural and remote people in New South Wales compared to those in South Australia, for example, because New South Wales, they're going to have to get their medication some other way. South Australia, they can get it through the S100 scheme.
And is there any evidence that adherence to medications is lower in the cities?
I'm not sure that there's actually ever been done a trial, but it's really a well-known phenomenon that people come to the city and they don't get their medication because they no longer have access to the S100. The Aboriginal medical officers in Adelaide are continually lobbying the Commonwealth to make the S100 drugs available to city people, and particularly to the rural and remote people who come to the city.
A nurse in Central Queensland asks, is there any simple way of assessing diabetes risk in Indigenous people? Would we use the AusD risk tool?
Well, I think you can certainly use that tool.
But Samara reckons there's not much cop.
That's right, isn't it?
No, it's not designed for Indigenous. They've got a different body frame to Asian, so you can't just throw everyone in and say, we'll just use this. As I said, the best way is waist-hip ratio.
The jury may be out. Well, personally, the way I would use the risk assessment tool is to show people that if you're, say, like many of my patients, Aboriginal and have a family history of diabetes, you've already got 5 points on your way to 15 points of being at the high risk. However, the other points, the other risk factors are actually things that you don't necessarily have to have. You don't have to be a smoker. You don't have to actually, you can eat vegetables and fruit each day. You can do some exercise. So you can actually...
So it points out a way of showing how you can change your behaviour as much as anything else. Jane from the North Coast of New South Wales asks, how early should we start screening Aboriginal people for diabetes? Pat?
The comment was made by the earlier speakers that they've seen children aged 9 and 10, and I think Rob has the practice of starting screening aged 10, and that seems like a very reasonable thing. I think it's also just worth commenting here is that the teenage girls, it's particularly important to look out for early pregnancy because those girls then get gestational diabetes, and that has adverse outcomes for their pregnancy, but also for the child. So I think that group in the younger women is a really important group.
Samara, what do you think?
I think that's a good point, yeah. We have to screen them at the age of 10, and the younger women as well, and get them prepared for pregnancy instead of unplanned pregnancy. Those sort of things have to be addressed and reviewed as well, yes.
Let's get the results of your last question. Does your service have a local Indigenous diabetes education program to which you can make referrals? The answer is half of you yes, half of you no, and a little bit of you say that it's part of your service. So the next question for you is, have you received any education and training on issues relevant to the prevention, treatment and management of diabetes in Indigenous Australians? Yes or no? We're not giving you a little bit of option here, so let's see what your answers are to that. Let's go to our next film case study, the Antigenes Good Health Team, and it's built around the idea that better results for chronic disease management can be achieved if the community works together with the elders leading the way. The programme is a comprehensive approach to improved self-management in Indigenous people. Let's have a look.
It's named after Auntie Jean Morris, who was a very much respected elder in the Illawarra. She did a lot of volunteer work for the community over her lifetime, and she passed away. Permission from her family was sought to use her photograph and her name as the Good Health Team.
I first came here, my sugar level was about 19. Now it's dropped back down to 4 and 5, you know, so it's good for me.
Aches and pains like the flu.
Aboriginal people don't go to the doctor until they have to. It's a last minute thing with the Aboriginal people. They won't go to doctors. But coming up here, I know where I stand with my health.
I think it's the creation of a culturally safe environment. Most of the people have chronic illness, and we look beyond the clinic rather than the prescriptive, which is normally clinical focus, which is normally given in other programs. We look at abilities, not disabilities, wellness rather than illness, strengths, and really engaging people and letting them build up their confidence in self-managing. And I think in that culturally safe environment it works really well.
Okay, so we're going to push down, in, out, and then back down.
We saw the need when Caroline first came onto the program as the program manager. She'd done some background work in talking to other service providers and organisations and asking about what they actually provided for Aboriginal people with chronic care or chronic conditions. And she found that there was a great big gap in service provision. Some of the programs were either too wordy and there was a lot of reading material. And the other thing, I guess, was isolation. They felt isolated because they didn't have other crew people attending the program, etc. And some of them found it difficult. So those were some of the findings. And we did some community consultations and asked the Aboriginal community in the Illawarra and Shoalhaven and their carers what they could identify as gaps in service provision to them as well. We invited a group of elders in the Illawarra to help us put the framework and the flesh, I guess, of the program together.
For their wound care.
I'm one of the first and still attending, and I was very down and very depressed. I used to hate to get up and face the day, but coming here every week I've enjoyed it. It was something to get out of bed for. I'm not sitting around waiting to die now. I couldn't even move on Friday. I'm living a beautiful retirement. Much better than what my mum did. They didn't have all this around them, but I have, and I'm very grateful for it.
I went to the Wollongong specialist for the kidneys, and he said to me, well, I'm afraid I think we'll have to take your kidney out.
And I said, you're not taking parts of my body. I'm not giving them away. And he said to me, well, get into exercises and so forth. I started doing weights here Mondays and Tuesdays. And then I went back and saw the doctor 6 months later, and he was so thrilled. He said, whatever I'm doing there, he said, keep up the good work. He said he wished all the patients would have been just as healthy what I am now.
Some people are actually staying out of hospital because of the program. Those people with really chronic and complex conditions come along and they're, you know, improving their flexibility and strength and learning to manage more.
I do exercise, which I've never ever done. I get up in the morning and I start walking. I've never ever done that, never. Because I used to sit home and feel sorry for myself. But now I've got a life.
I can walk further, I can swim better, and I can annoy a lot of people a lot better too now. I can touch my toes and do up my shoes easy without puffing and blowing, because since I've been doing this, I've also gone off the asthma machine as well. I only use the puffers now because I was an asthmatic when I first came here.
You have to have good nutrients, so that means you've got to be eating the right thing. For diabetic people, your blood sugars must be under control.
They help us. They talk to you and explain everything to you, you know, with your diabetes and things like that. And your sugar level was just high too. This means a lot to me. I wouldn't stop coming here because this is my family, my friends.
So only for Auntie Jean's exercise classes, it's really put me on top of the world.
The Auntie Jean's Good Health Programme. Rob, what do you think?
I think it's fantastic. My only concern with this type of program is that people go often enough for that to get that exercise regularly throughout the week. And my only concern was one of the comments from one of the ladies was that she looks forward to the Auntie Jean's program every week.
And I suppose, Samara, if you look at it, you think, well, gosh, what are they actually doing there? They're moving their feet up and down. Are they actually doing anything significant? But in fact, that's actually movement against a background, not just for Indigenous people, but for non-Indigenous people too, where there's obviously, there's probably not very much movement in their lives.
No, that's a good program. Out in the remote areas, they don't think about like exercising because they think, oh, we live a long way, so we're exercising, walking around.
We're exercising, driving the
Toyota, you know, and stuff like that. But yeah, the communities have to start be community driven and start exercise programs in the communities. And a lot of the problems is dogs, you know, getting bitten by dogs and stuff like that. And what we say is just take a group of yous out and just go for a walk. You know, along the beach, it's beautiful. And a lot of those areas are spectacular views. And it's just people supporting and just prompting people, I think.
And your programme is basically an outreach programme going to those communities and has links to specialists, etc.
Yes, well, we promote self-management. We give them the tools to make changes and ongoing education, support, and we do outreach from Port Keats over to Borroloola, so we've got the top end. So, yeah. And
so you spent your life in a Toyota?
No, aeroplane.
Too far to go.
Yeah, and we do follow-ups with them and stuff like that, so we're in contact with them. So, yeah, we're slowly doing it. We've only a small team, but...
So I think we've got the results of your last question. Have you received any training on issues relevant to the prevention treatment of diabetes in Indigenous Australians? And 3/4 of you are saying yes, and 1/4 of you no. Let's just talk quickly about complications and the management of complications. Rob, what should be the approach here?
I think it's prevention. I think we, you know, from diagnosis we brief the patient that because they have a condition which can affect many parts of the body, we're going to have many experts looking to prevent those problems occurring. And I think we make sure they're off to the ophthalmologist for an initial visit, off to the podiatrist, the diabetes educator, and other people as needed, perhaps the endocrinologist if it's a young or an unusual case.
Pat, I mean, what about management of the complications and prevention? We spoke earlier about medications, and I suppose we should really talk about blood sugar control in this group and the medication regimes. Just remind people what the approach is.
For non-Indigenous people, there's a tablet which is called the type 2 tablet, which is recommended for all people who've got type 2 diabetes, and that's got metformin, a statin, ACE inhibitor and aspirin in it. And in an ideal world, everyone who has type 2 diabetes would take those medications, which are pretty evidence-based in terms of reducing the risk. Now, that would apply even more probably to the Indigenous population, but then you've got the problem that it's 4 different medications, it's 6 different medication taking occasions, so it's quite a burden. And I think in medication, one probably needs to say, so what's giving us likely to give us the best bang for our buck? And I think we can be pretty confident with metformin, we can be pretty confident with ACE inhibitors, we're pretty confident with insulin. They are 3 good medications. And blood glucose control is important because of the microvascular complications. And if you don't develop neuropathy, you probably won't get foot problems. And if you don't develop nephropathy, your risk of cardiovascular disease is also very much less. So glycemic control and blood pressure control are really important priorities because the blood pressure also predisposes to kidney disease.
But the guidelines say no insulin until you've maxed out on your oral hypoglycemics.
Well, that's not entirely true either. The Americans and Europeans have recently come out with a guideline that says you start with metformin, your next medication could be a sulfonylurea, it could be insulin, it could be a glitazone, it could be one of the other less commonly used medications. So I think people are recognising that insulin is very likely to be needed at some stage, and earlier may not be a bad idea.
And Samara, how well or badly do people cope with hypoglycemia, particularly when you get onto the sulfonylureas and insulin?
We make sure they're self-monitoring. We don't put anyone on insulin unless they're self-monitoring. They do manage. We have blind people doing insulin injections, and they count the clicks. Those sort of tools, you know, we try and work out what's good for them, and with the right information and the right tools, people can do things.
And in the top end, and in Cape York, what do you do about retinal screening, foot care, that sort of thing?
We have a podiatrist who travels with us, and plus most of the health workers in any of the communities know how to do simple assessment forms as well. And there's an eye team that comes up a couple of times a year up there as well. Plus we link in with the endocrinologist does a visit up there from the Cairns Diabetes Centre, and we also link in with the Cairns Diabetes Centre, so if there's foot problems or whatever, we telehealth in, video conference into them as well. So we're in constant contact with specialist areas as well for that.
It's been fascinating. Thank you all very much indeed. What are your take-home messages from people from the programme? Bernadette?
Educate people as much as you can, keep it simple, so that you can empower them. Yeah, because if they can be the boss of their diabetes, I think that's where we're going to see changes, when the people feel they're in control. Make it a positive story and no growling.
No growling, okay.
No growling.
No bullying. You're not a bully, Samara.
No, we don't do bullying. I think it's just being consistent, being supportive and being truthful. And, you know, everyone's got holes in their feet. They do muck up. They, you know, get off track. Just have the patience to help them back on track. Yeah.
Rob?
Treat the individual, and I think be positive about the story that they're actually the people who can control most of the risk factors in their diabetes.
Pat?
Assume all people with of Aboriginal descent are very likely to get diabetes. I think screen Aboriginal people at regular intervals, for example yearly. Intervene actively insofar as one can with metformin, ACE inhibitors in particular, and monitor for complications, particularly for neuropathy, because that is the way you'll prevent foot problems.
Thank you all very much, and I hope you've enjoyed the programme on type 2 diabetes and Indigenous Australians. Got a lot from it, I certainly have. And this series will be available of all 4 programmes in December, and that'll be free on DVD, and if you want to order, you visit the Foundation's website. And if you're interested in obtaining more information about the issues raised tonight, there are a number of resources available on the website at rhef.com.au, and that includes links to all the new type 2 diabetes guidelines. Don't forget to complete and send in your evaluation forms, and please register for CPD points by completing your evaluation form. I'm Norman Swan, and I'll see you next time.